Welcome everybody to Grand Rounds in Population and Public Health Sciences, put on by the Department of Population and Public Health Sciences here at the Keck School of Medicine of the University of Southern California. Today I have the great pleasure and privilege of introducing our speaker, Dr. Prabhat Jha. I also want to thank our panelists today, which include Adam Leventhal, the director of the Institute for Addiction Studies here at the University of Southern California, and Heather Wickley, who's arriving a little bit late. She's one of our professors also, and a global tobacco expert. So Dr. Jha, I've had the pleasure of knowing since 2012 when I arrived at the University of Toronto. I quickly found out that Dr. Jha was one of our great stars at the School of Public Health. He's a physician, also got his PhD, was a Rhodes Scholar, and has this incredible pedigree of not only being a world-class epidemiologist, but also being trained in economics. He worked at the World Bank, and the subject of today's talk, Grand Rounds on Tobacco, was something that he worked on while I was at the World Bank and put out one of the seminal reports on global tobacco, its threats, and how to approach it, and has been a key figure in promoting taxation as a policy tool for controlling the tobacco epidemic. I think we're going to be hearing something about that, while at the same time pursuing, as an epidemiologist, the impact of tobacco on societies worldwide. And while I talked about a few of his honorifics, including the selection to the National Academy of Medicine here a few years ago, and winning the American Public Health Association Research Award, what I didn't mention in the flyer was that he's also the creator of the Million Death Study, one of the great studies that encompass demographics and uses the verbal autopsy tool to understand the true causes of death in many countries around the world, which began in India. So that's probably enough for now. They've got a pretty fulsome talk ahead of us, so please welcome Dr. Prabhat Jha. Great, stay close to the mic.
Thank you very much, Howard, for the invitation. Let me start by giving you my conclusions, which is that really I wanted to get across a few key points, much of which would be familiar to you already, but I'd like to show you some updated evidence, some of which is still being reviewed. So first is that smokers who start early and don't quit can expect to lose at least a decade of life. Second is that smoking accounts for about half of the excess deaths in lower education US white adults. So I'll show you some new evidence on that. Third, again widely known, is that adults who stop smoking, but preferably as early as possible, substantially reduce excess risk. But I'll show you new evidence that that's surprisingly quick. Within a few years, cessation gives you enormous benefits. And finally, cessation is low in many parts of the world, and it's also reasonably low in lower education groups. And the key strategy to raise cessation, which I'll spend a bit of time, is excise taxation, which remains underused everywhere. So I'm going to give you a fair number of numbers in the talk, and I apologize for that. That's the criticism of epidemiologists, is that, we're number crunchers like accountants. That's not fair. Accountants have far more personality. But the numbers, I think, help guide what we want to do, is try to explain the core messages around risks to the politicians and to the public. So for the public, this, I'm sure you've heard from Richard Pito and others, there's really three big messages for the individual smokers. The risk is big, half are killed, at least half, and a quarter of those die in middle age, losing many years, many decades, and that's stopping smoking effectively. So let me start by doing a quick comparison of other risks and I'll come back to smoking. So worldwide, the World Health Organization said roughly there's about 1 billion smokers, 2 billion drinkers, about 600 million obese or adiposity with a BMI above 30. And the annual numbers of deaths for each of these is actually greatest for smoking. So let's start with a comparison of alcohol. And the simple message here is don't drink like a Russian male. If you compare the Russian mortality pattern, so this is in women, over time, you see these remarkable fluctuations that occurred in contrast to the UK, which by no means is an abstinent population, but you see that there was no overall increase, in fact, a steady decrease in death rates in the UK, but big fluctuations in women in Russia. Now, what is behind this? Well, to really understand it, look at men and look at these extraordinary fluctuations that occur in overall mortality at ages where deaths shouldn't occur. And it is very much driven by restrictions in alcohol use or in increases at times of social crises. So you see what happened here is Gorbachev came in, didn't like to see so many drunk men in Moscow, and so he imposed policies that restricted alcohol use, and sure enough, there was a big decline in alcohol mortality. The Soviet Union collapsed, and in came Boris Yeltsin, who we all remember was famous for his own drinking, and there was a huge increase in mortality, and very much driven by excess vodka. And then another collapse. So basically, social collapses in the Soviet Union and in Russia have been mostly mediating a big excess of deaths from binge drinking and alcohol, and that's what drives this excess. And this was shown very nicely after a fair amount of controversy, because epidemiologists working on this said, well, look, we know from some evidence that even modest amounts or even larger amounts of alcohol should have some cardioprotective effects. But David Zaridze and team in Siberia really sorted this very nicely. And what they did is, in Siberia, they studied men and women who had died, and then went back and asked after their death in the household, what did they drink? And they compared men who drank a bottle of vodka a day to those that drank only a bottle a week. And there were no drinking controls, no non-drinking controls. And you get actually accurate answers by asking women after the husband has dropped dead, what did they drink? And then they saw this big excess in all of the major causes, not just from what you would expect, road traffic accidents, injuries, and violence, but also from medical cause. And one of the things that was surprising is that the excess deaths were being shown from cardiac conditions, but it was simply a Russian coding convention. That the ICD code that they used, I-24, was that you basically drink until you get an arrhythmia, and that's coded as a cardiac death, but effectively it's an alcohol toxicity death. And so David's study really sorted this out very nicely, that the main excess. Now that's Russia. So Russia is one of the few places where smoking, where alcohol does cause more deaths than smoking, but in most other places it's not the case. So let's consider adiposity, and this has been said, oh, okay, well, what about being severely overweight? Well, as I'll show you, a typical smoker can expect to lose a decade of life. That was first established by Richard Dalla in the last follow-up of the British Doctor study, and has been confirmed subsequently. But to get the same decade of life from obesity, you have to have a really high level of adiposity. In my case, it would be putting on another 100 pounds, and keeping it on my whole life would give me the same loss of life as being a typical smoker. And with more modest obesity, around a BMI of not over 30, but let's say up to about 30, then you get about a 3-year loss of life. And then if you do the maths in the US, you say, well, 30% are obese above a BMI of 27, and about 20% smoke. So the 20% of the population effectively knocks life expectancy down by 1 year. The 30% who are obese multiplied by an excess risk of about 0.3 knocks about a year off life expectancy. So still in the US, obesity is currently constituting less loss of life than is smoking. Okay, let's turn to other exposures that have been suggested as comparison, one of which is ambient air pollution. And the place to study ambient air pollution at very high levels wouldn't be obviously in LA or in Vancouver or in Toronto, where most of the studies have been done, but you have to go out to India, which has very high vascular mortality rates and very, very high levels of particulate matter. So what we did on a paper co-authored with Howard is look in the Indian Million Death Study, which is a distributed sampling of mortality all over the country, and study the individual deaths and relate them to satellite exposures about 3 to 4 years earlier, between 3 to 6 years earlier. And the satellite exposures then give you particulate matter, and there are reasonably good correlations between what the satellites and local ground stations measures. And the satellite measures have gotten better over time, thanks to NASA making all these data available publicly. The measurements of exposure have really improved, but the main uncertainty is, okay, despite high exposure, how much deaths arise? And when we looked at the leading causes of death, which are heart attack and stroke, there was a surprisingly null association, or close to null association, with heart attack. And that varies either if you do a prospective analysis using overall mortality, or if you do a case control comparison where the comparisons are injury deaths, which shouldn't be related to air pollution. So there really was no association. For stroke, paradoxically, there was a protective effect, but if you then take into account covariates, there's a modest excess of stroke deaths in either approach. But heart attack, respiratory disease didn't really have any excess for every 10-unit increase. And then, as we know, dose-response relationships are the core of reliable epidemiology, and this then compares the dose response in the blue and the yellow show the Million Death Study and Salim Yusuf's PURE study, direct evidence of what is the dose response relationship with heart attack. And you see basically it's flat, with some uncertainty shown in the shaded. In the dotted lines are the various model-based estimates used by the global burden of disease. You see, it's inconsistent that there's no dose-response relationship in the two direct studies, but the model relationships show a steep relationship. And for stroke, it's a little more complicated. They both see upward relationships, but nothing as steep as seen in the models. And if you add respiratory disease, it looked like the heart attack ones, very little association. So this suggests that the GBD estimates based on models certainly have uncertainty. Our estimates have uncertainty, but they're not compatible, that the results suggest that the error that are probably inherent in models is far, far greater than what you would have in the direct estimates. So this suggests a real rethink about the approach to think about what are the mortality consequences. That's not an argument for not cleaning up particulate matter in Delhi, which is awful, or Delhi or all parts of India, which is awful, does contribute to respiratory disability, does contribute to childhood asthma. The arguments, I think, are strong enough, but the argument that air pollution is the new tobacco is actually, I think, quite misleading. And Dr. Tedros tweeted that, oh, particulate matter is the new tobacco, and I tweeted back, respectfully, Dr. Tedros, tobacco is the new tobacco. he didn't reply, but I think we're trying to make the point that the estimates, and as more evidence comes out, including from studies that have tried to replace household sources of particulate matter exposure, they're actually finding a much more modest effect on mortality. So I think this is one of the great misunderstood areas globally in terms of particulate matter risks. Okay, so I've talked about alcohol, obesity, particulate matter. What about something a little more esoteric like happiness? And so Valerie Burrell and Richard Pito looked at the UK Million Women study and asked a simple question saying, okay, if you're happy, what is your 10-year mortality? And if you're happy most of the time, usually or sometimes, if you correct for the fact that you have a baseline chronic disease, there's no relationship. But compare that to smoking, where even a modest amount of smoking significantly increases your risk. So the key message is, it's best to be an unhappy non-smoker. I used to be happy once, so I can kind of relate to this slide. Okay, so what do we know about the 21st century hazard? Surprisingly, we got evidence really around the time of Richard Dahl's birth centenary, which is in 2012. A bunch of investigators gathered in Oxford to honor his 100th birth centenary, and a lot of us went into the data and tried to understand what's happening with contemporary risks. And it seemed like we were colluding, but the studies more or less showed a really high risk. So this is, on the top you see, is the last study that Richard Dahl did, the British doctor study. This is the Million Women study. These are US studies, which I'll show you in some details. Japanese atomic bomb survivors and Indian men who smoke cigarettes. They all have a consistent loss of life of about a decade or more. So let me get in some details about smoking totals and their variation. And I'll start with, of course, the global estimates, which is roughly about 6 to 7 million. WHO says it's about 8 million, but they include passive smoking, which I think is vastly overestimated. And Richard Pito and others have said, well, they think it's about 7 million, which is close to my estimate, and it'll rise to about 10 million. And a simple way to think about this is every million sticks sold will eventually lead to one death. So that's one way you can track what are the overall numbers. So, but smoking contributions vary across populations. And when we looked in 4 middle or high-income countries, Poland now is a high-income country, the contribution of smoking to male mortality was such that it accounted for about half of the difference between rich or poor or higher or lower education groups. So if you take Canada, for example, that in the lowest income group, 35% of men would die between ages 35 to 69. But only 20% at the highest education group. And if you look at the shaded part, smoking accounted for a disproportionate proportion of that. So if you can imagine this graph, removing the gray shaded, the differences between rich and poor, higher and educated would be approximately halved. Well, we've recently looked into this in greater detail in the US in a paper that Shuang Tang is doing and under review at JAMA, which is looking at the 30-year trends in survival in US whites. We're focusing on US whites. And the reason for focusing on US whites is because they constitute 67% of the population, and that's where the main concerns that have been raised, for example, by Angus Deaton's phrasing about diseases of despair. And there's a few things. This is a busy slide, but let me point out a few things. So first, in the lowest education group, which is 0 to 11 years, the population is shrinking. It was 26 million in 1990, and now it's down to 14 million. So that's good news. The overall population size of the lowest education group and the highest education groups are increasing. That's good. Education levels are rising. But look at the risk of death between ages 15 to 79. And a fair public health proposition is you can't live forever, but between ages 15 to 80, approximately, death rates should be low. There's no reason that you should have any significant death rates in that population. And look at what happened in 1990. And there was, of course, differences. It was 53% dead in the lowest education group versus 39% in the highest education group. But by approximately 2019, look at the big divergence. In the high education groups, that went from 39 to 30%. That rate of progress is about what you see in Canada, Norway, UK, others. They chugged along as other places have. But look at the remarkable variation in the lowest education group. 74% at these death rates of 15-year-olds in the lowest education group can expect to be dead before age 80. That mortality risk is as high as many parts of Africa. I mean, it's extraordinary what has happened in the lowest education group. And then naturally the gap between the absolute gap in mortality risk between the highest and lowest education groups has considerably increased. Now, other ethnicities, which I'll leave for the moment, tell a very different story, and it's made more complex by the fact that among the Hispanic communities, you have a fair amount of in-migration of healthier Hispanics populations. And in US blacks, there is an extraordinary good news story that we're not going to cover here about convergence with mortality in white populations, except in the lowest education groups. But let me focus here on US whites, because that's the concern around probably the diseases of despair. So this shows the same findings, but now between 1990 and 2021. And this pointer works, I'm not sure it does. Oh, here it is, okay. So what happened? Well, at 15 to 29, which is really only 3% of deaths in the US, so this is not a big contributor to the overall mortality, but still you see a big increase over time in the lowest education group's mortality. That's 0 to 11 year. Low education group mortality steadily rising. In those with 12 years was also rising, and those with 13 or more years of education, pretty flat, which is shown here. And during the time of COVID, the lowest education groups at all ages were notably had higher death rates during the COVID time. So for the rest of the analysis, we're not going to worry about anything after 2020. We'll focus up to 2019. But you see this big divergence that's been well described. So overall death rates shown in the blue in the US have stagnated in middle ages. They've come down only modestly at older ages, both in men and women. But the main driver of that is not the higher education groups. You see that's actually coming down in the older ages and somewhat in the 30 to 64. But it's really the lowest education group and the middle education group. So let's delve into this a little more detail. And so here, now we're looking at excess mortality. And the definition of excess is now at 30 to 64 and 65 to 79. And so this again is the education groups, low, middle, high. And that's the starting dot and that's the end dot. The end dot for low education is a very simple application. It's not saying that the lowest education group will become like the highest education group. But what it is saying is the rate of annual progress in the highest education group should be also occurring in the lowest two education groups. It's a very simple metric, annual rate of progress, not the level change. So you're not making people equal, but you're assuming they're equally progressive in terms of mortality reductions. And if you do that estimate, then you end up with a very large number of avoidable deaths. At least in the last time period, about 500,000 in the lowest education group versus the highest. In the middle, 900,000 between the middle education group and the highest, just in men 30 to 64 and comparably. So we're focusing on excess mortality here from slow rates or stagnation of rates of progress. Okay, now let's look at this by causes, which is where it gets really interesting. So what we've done is define the causes really into three key categories. One are smoking attributable deaths, and this is based upon looking at lung cancer rates in each of those populations and indexing the absolute lung cancer rates to the relative risks from other conditions, vascular, respiratory, other cancers. And there's some statistical problems with doing that, but I think we've done it very carefully and not avoided any excess or spuriously high estimates. And look what happened with smoking attributable conditions in the lowest education group, really shot up. But even in the middle education group, there's actually some progress. And in the highest education group, smoking rates are coming down. If you go to older ages, it's even more dramatic. The low education groups are seeing rising smoking deaths, but broadly, in the middle and higher education groups, smoking rates and smoking deaths are coming down. And the same story in women, pretty much. What about the next set of conditions, so-called diseases of despair, which we called OCE, which is opioid cirrhosis external causes. It includes suicides and a bunch of other conditions. There you see a marked increase in all three education groups. So being educated didn't really protect against the big excess, and that's particularly from opioids. I think, being educated didn't protect you against the marketing from Purdue and the big push and the access to cheap, particularly synthetic opioids that came from China in large numbers. So here we made an adjustment about rates of progress, but this is really confined both to 15 to 29, but it's not at older ages. So it's really a phenomenon at younger ages, not at ages 65 or older. And then for all other conditions, by subtraction, this is everything else. And here you see again some increasing causes of death in the lowest education groups, more noise in the upper education group, or the upper ages, but still the lowest education group continues to make good overall progress. So now this is some of the details of the OCE conditions, and they're quite variable. They probably should be analyzed separately, but you see big increases in opioids, but also in cirrhosis. Not so much assaults, and that's been feared that it's violence, but it is for guns, but some of that is misclassified suicide, but so-called gun-related accidents, firearms. But interesting, even vehicle traffics, accidents. So it's a very unusual bag that's contributing to these conditions. Okay, so what does this mean? Well, over the 30-year time period, at 30 to 79, there's been approximately 5.5 million excess deaths in the two lowest education groups versus the highest. That's over the 30 years. And of that, in the orange is shown the contribution of smoking, and that accounts for roughly 55 to 56%. OCE conditions are 10 to 14% over that time period. But this has changed over time. In the last decade, both smoking and OCE account for a third of the excess. So that's both falling smoking, but increasing opioids. And that's really focused on 30 to 64, because opioids and OCE conditions are not causing much deaths above age 65. So the key point I take away is that the excess deaths, the so-called diseases of despair, dialogue in the US has paid inadequate attention to the role of smoking attributable diseases. Now, is this This is all well and good, but can you actually do something about it? Yes. In Ontario, in Canada, where there's been taking tobacco control realistically and for some time, look what happened over a 20-year period. Well, we've got the poorest men, this is not education, but the poorest neighborhood of men and the richest men. So of course in 1990, you see that there were big differences in overall survival between 30 to 69. 30% of the poorest men would be dead, but only 21% of the richest men in 1990. So there was a difference. But over time, both have fallen. And of course, the inequalities continue, 25 versus 14. But if you look at the difference, well, the risk of death fell here by 5% absolute. The risk of death in the richest fell by 7% in absolute, 21 to 14. And then say, all right, let's look at the contribution of smoking to those. And smoking attributable diseases, well, roughly 3 out of that 5, or 60%, of the declines in the lowest or the poorest men was due to less smoking deaths. In the richest, only 2 out of the 7, or about 30%, was due to smoking. So effectively, mortality declines from smoking attributable conditions have narrowed the absolute gaps between rich and poor, but not yet in the United States. Okay, let me turn back to the rest of the world. US is interesting, but it's still only about a small proportion of the world's population. So let's turn to the other ones. Well, China, of course, is home to about 1 in 3 of all smokers worldwide, and sensibly, the Chinese men are Chinese women don't smoke, Chinese men do, and that's where you can study smoking in serious ways. So what has happened over time? Well, in the 1990s, about 12% of deaths in middle age were due to smoking. Oops. And that rose to 20% by 2010, but more in urban areas than rural. And it'll reach 33%. And we know that because that's approximately the proportion that the US and Canada stabilized at, but also more directly in Hong Kong, just across the water, who started smoking, the men started smoking 20 years earlier, and they've plateaued about a 33% of all middle-aged mortality due to smoking. India is different because of different smoking patterns, but again, male-dominated. Males are the ones that smoke in India. And here you see that men who smoke bidis, the local manufactured cigarettes, lose 6 years of life. The very few women who smoke, they smoke bidis, they lose 8 years. Men who smoke cigarettes lose 10 years of life. And what has happened is over time, smoking has changed. Bidis are being replaced by cigarettes, and the amount, although the smoking prevalence has fallen, the hazards continue to become more extreme. So over a approximately 10-year observation period, for all medical causes, cancers, respiratory, and cardiovascular, the excess risks or the odds ratios are actually increasing over time. And this is particularly noted when you look at heavy patterns. So the tobacco industry's goal in India is not so much to recruit new smokers, but they want to switch over bidi smokers and say upgrade to cigarettes. And they would very much like Indians to smoke in Western patterns, which is about 10 a day and not 1 or 2 a day. So, and the strategy would lead to clearly a big excess in deaths. You see that's the higher amounts of smoking, and over time the risks have become more extreme. Okay, so because the hazards of smoking are so large, the benefits of quitting are ridiculously effective. So quitting by 30, or by age 30, gets you back nearly the full 10 years of lost life. But even quitting by age 50 gets back 6 years of lost life. And this has been established for even conditions that we think, oh, well, you know, it's too late. You've been smoking your whole life and you're going to get lung cancer. So if you look at lung cancer mortality in US or the UK, even those that quit by age 50 avoided about 2/3 of the continued risk. And this is important. There's so many smokers, 60 million smokers in Canada, the US, UK, Norway, which is the comparison countries where I'm going to turn to next, continue to smoke. And many of them say, oh, it's too late for me. I started when I'm 16 and it's too late. I might as well keep going. And you say, no, you actually get huge benefit. But worldwide, smoking cessation remains really uncommon in large parts where there's large numbers of smokers. That's Russia, China, India, Indonesia. But there is good news. If you look at the ratio of former to current smokers, which is a simple way of monitoring quitting, look that North America has got now a lot more former smokers than current smokers. And even a place like Brazil, through aggressive excise tax, was able to now get a lot more of the adult population to be former versus current. The African population is a little uncertain because of survey data. So the big challenge of global tobacco is really focused on Asia and including on Russia. Okay, let me show you some new evidence about how quickly cessation works. So this is in press NEJM evidence done by Oren Cho, and we put together 4 studies: the US NHIS, the Canadian Community Health Survey, the Norwegian cohorts, and the UK Biobank, and examined in all of those studies what were the hazard ratios of continuing to smoke and of quitting. And again, no surprise here, look at the huge excess risks or the hazard ratios for current smoking for respiratory disease versus former. And overall, it's 2.7 is your hazard ratio for current smoking, men and women approximately the same, versus 1.3 for former smoking. So right away you can see there's an 80% excess risk, right? There's 170% excess risk here versus a 30%, so it's a 70% reduction or 80% reduction in excess risk. But you have to look at that by age of quitting and also how long they've quit. So this analysis shows that the excess risk difference is clearly largest if you quit early, below age 40, no matter how long you've quit. So there is a clear gradient. But if we focus on, and this is true in women, and it's true in men, but if we focus on age at quitting, those that quit by 40, this graph is, again, a little bit busy, but look at the survival from 40 to 79 in current smokers. It's the same kind of graph that I showed you earlier. And look at it in never smokers, which is the top, and former smokers in the red. So never and former smokers look almost identical if you quit before 40. So you get back almost all of the lost life. But quitting during age 40 to 49, well, you're not quite at never smoker death rates, but you still get back 6 years of lost life. And even quitting at 50 to 59 in this analysis gives you back about 3 years of lost life. The other way to look at this now is, okay, what if I've quit for only 3 years versus I've quit for 10 years? How much benefit will I get? Well, these show for overall mortality that you get back, if you're a long-term quitter, you get back 10 years of lost life, but you get back about half of that from cessation just within 3 years. And that's remarkably quick. It's both for men and for women. And this shows in tabular form the same comparison. So you look at the versus never smokers, there's 12 to 13 years of lost life for men and women. But of that, if you are a quitter of less than 3 years, you get back a substantial sum of that eventual lost life really quickly. It varies by condition, and you see for respiratory disease, you're getting back less quickly as a proportion of the overall loss, that which is greater, but there's still benefit. So quitting at any age is effective, and quitting at any age is remarkably quickly effective, is the key message out of this analysis. Okay, let me turn to tobacco control and excise taxation. So the work, as Howard mentioned, that really laid the basis for what can be done globally was done in 1999 and followed up subsequently. There's been some other reports, including the WHO Empower report, but the conclusions broadly are the same, that what is really important is getting current smokers to quit and getting higher cessation rates through taxation. So interestingly, when you look at taxation, one of the key things economists look at is the price elasticity. If you raise the price, how much do people quit smoking? And up until about 3 decades ago, public health people didn't believe that higher taxes really worked in reducing consumption. And kudos to people like Ken Warner at University of Michigan, who kept hammering the evidence that taxes really work. And then I looked into some animal studies that effectively have tried to establish price elasticity in primates or in mice species. And interestingly, they all show a price elasticity curve that's very similar to humans, and basically centering around -4. And so it suggests that we might have a built-in endogenous price responsiveness. Just somehow it's conserved in evolution, our evolution. They didn't test smoking here, and this is expressed as units of work or some reward, but you find a surprisingly consistent addictive price elasticity curve across species. Okay, well, let's look at real people now and what towards.
Can you define what price elasticity is for those of us who are not?
Sure. So price elasticity is simply for a given unit increase in price, how much will be the reduction in consumption? So typically what in smoking, that's estimated at a -0.4. That means in this case, if I have 100% higher price, then my overall consumption will go down 40%. And of that, 20% involve current smokers to quit, and 20% mean the smokers smoke less. So instead of 10 a day, they might cut back to 5. Now, the main benefits of tobacco control are not from smoking less, it's from quitting. And so the emphasis here is that if we had 100% higher price, it would mean 20% of current smokers to quit. And when you look at the price elasticity studies, and we put together first meta-analysis of 100 of these in 1999, which has been subsequently updated, a few things are first, greater effects in the poor and in the youth because they're just more income responsive or price responsive. A big single increase has a greater impact than smaller increases. And even the experience that's been done in California with the big hike that was done in the 80s showed that continue to have benefits, but it's certainly time for a new one if Jeff can get to Governor Newsom and say that's the next thing he should do, is a big tax hike. Yep.
Just a quick question, when you say raise it 100%, does that mean doubling the price?
Yeah, doubling the price. And you have to look at the tax hike would be even bigger on that because it depends on the base cost. So, but we're looking at really large tax hikes, which I'll show you are very practical.
And what's tax in animal studies?
The animals in, those were units of work or units of reward as the same measure of price elasticities. But what is remarkable is that 0.4 seems to jump out consistently across addictive goods across species. And that's why I think it might be evolutionary conserved somehow. So we've got a big tax hike is more effective, and actually probably is more effective in part because it also sends a signal to the population saying, uh-oh, this is a big hit and I should reduce my consumption going forward. And despite the concern that, oh, okay, it doesn't work at high prices, it does. And despite the concern that, oh, well, wait a minute, there's this hardcore addicted smoker that's never going to quit. If you look carefully, even in the more addicted populations, they do respond to price. So there's lots of myths about how well taxes work. Okay, let's show some real evidence. So what happened in France? Well, These aren't primates data, these are data on French men and women. And what happened? Well, in France, they were able to have consumption very quickly versus other countries. They went from about 6 cigarettes per adult per day down to 3 within 15 years. In Canada, it took us 45 years. In the US, about 40 years to do the same halving. And the reason is Jacques Chirac at that time decided to raise taxes, which is shown in the red, very aggressively. So the price index effectively tripled. So the tax hike was even bigger than that. And this is contraband smuggling, which actually did come down, which I'll come back to. And one way to look at that is if one studies lung cancer at young ages, like very young, 35, 39, A, it's rare, B, it's very well diagnosed, and C, it's almost all attributable to smoking. The non-smoker lung cancer rates haven't changed over time, so this is all attributable to really smoking. Look what happened in males in France. They were going up, and the tax hike started to occur, and really within 7 years, boom, they started to fall. And the female lung cancer rates, which were rising, was effectively aborted. Now, this is not all price effects. There probably is some issue about the change in the type of cigarettes. They went from smoking the higher tire Gauloise to the more contemporary brands, but you see the French decline was actually much steeper and faster than in Germany or the EU overall. Now we have a control group for, this is nice policy. This is where you just raise taxes and things come down and the tobacco industry doesn't interfere. But we have a nice case study where the tobacco industry says, oh, we don't like this and we're going to interfere, which is Canada. So what happened? Well, in fact, in Canada, consumption started to go down even earlier in the 1980s because the feds started raising taxes. And the tobacco industry got together, and this has actually been documented. The 6 of the major tobacco industries got together and said, well, these Canadians are a little getting too cocky, why don't we make an example out of them? And so they organized smuggling across the US-Canadian border, buying Canadian cigarettes, exporting them free. They would end up on the indigenous reserves across the border, and then they were smuggled back in to Canada, and they call the TV networks and says, oh, go on this bridge, and you see all these boats with smuggled cigarettes. And this was meant to scare Jean Chrétien and Paul Martin, the finance minister, and it worked. Look what they did, is they lowered the tax, so boom, the tax fell, youth consumption went up, and eventually they said, look, we've been duped by the tobacco industry. They sued them, got a paltry $1 billion settlement for smuggling, and then eventually they were able to raise taxes again. But this lost decade, which I call Canadian tax policy, well, what happened there? Well, roughly 30 to 40 billion sticks were sold in that early 1990s. And much of that would have been excess sticks. So remember that statistic, that every million cigarettes is one death. Well, the tobacco industry has probably contributed to perhaps 30,000 excess deaths eventually in Canada from this stunt. And a third of those are going to be from cancer. And more importantly, they go around the world and say, oh, look what happened. They hire that economist, Laffer, who talks about the famous Laffer curve, and he has a graph like this. He doesn't show the other side, he just stops there and says, look what happens. You can get so much smuggling, you shouldn't raise taxes, you should cut taxes. So the industry succeeded at the expense of Canadian lives in creating an example that they showcase around the world. Okay, let me turn to, in the last parts, the Framework Convention on Tobacco Control, which Howard mentioned. This is the main instrument that WHO uses to try to curb global consumption. And so Guillermo Coraje in Chile has done with us an analysis coming out in Nature Medicine saying, what is the impact of this global treaty? And earlier analysis hadn't quite taken into account a really important detail, which is you want to look at when was this act actually ratified in countries and when did it take place? And so this is what we've done using an interrupted time series analysis, which economists like to do a lot. It's an alternative to randomized trials. And so what we did is pretty simple: compare pre and post trends in prevalence, numbers of smokers, quit ratios. And then we're using here data from about 170 countries using the Global Burden of Disease survey analysis. I'm a critic of the GBD estimates in many ways, but I think the smoking data that they put together by Emmanuel Gaikadu is really well done. And then we're looking at what happened over 10 years. And for this analysis, we included China, which is a third of global consumption, but also has very peculiar internal market dynamics, which make this kind of analysis difficult. So this is how ITS works. It's kind of a simple methodology, but you have an observed pattern, and then you're able to see, okay, given a particular year, which is the year the Framework Convention was implemented in that country, did the levels of consumption change? Or if they didn't change, was the slope, the trend, any different? So most of what I'm going to show is the acceleration of the trend. And here's the key result. So after 10 years, there were about 16% fewer smokers below age 25. There was 8% lower prevalence below age 25, an increase in quit ratio. But that's in overall countries. In the subset of about 30 countries that not just raised the FCTC, but they raised taxes concurrently, there was a much bigger impact. 28% fewer smokers, 22% lower, and greater increase in quit ratios. And so this, you put in absolute terms, it suggests that there were 24 million fewer smokers just in the 10 years from the FCTC. But if all countries did what the high tax countries did, we would add 44 million fewer smokers. And this is just shown graphically. So this is the observed trend if nothing had changed, and then this is the trend that occurred observed, and the dotted is if they all did what high tax countries did. So this is the same graphic. This just shows what happens in high tax countries, a greater impact. So what does this mean for policy? Well, it means that all governments, including the US and the European Union, aren't taking taxation seriously as part of their cancer strategy. So President Biden's moonshot on cancer, of which he's been a terrific champion, initially had slightly different goals, but the newer goal is to have cancer death rates by 2025 and improve the lives of people with cancer and cancer survivals. Well, I'll submit that a tripling of the US federal excise tax, ideally not just from 1 to 3, but to $5, would actually double the rate of decline in cancer mortality in middle age and reduce inequalities, as I showed you. In the EU, they've got this ambitious goal of 5% smoking prevalence by 2040, but there's no way they'll get there because the tobacco tax directive is too small. And what's needed is 100% or more increase in price, as France was able to do. So Andreas Charmblos from the European Oncology Forum, we have got a letter coming out in Lancet Oncology asking the EU plan really needs to be rethought. And I hope in the US those would be considerations as well. So let me conclude with the same key points. Smokers lose at least a decade of life if they don't quit. And it accounts for at least half of the excess deaths in lower education whites and in other settings. Stopping smoking is ridiculously effective and quickly effective. But cessation, which is the main goal, remains really too low in very large populations, including lower education. And the title is called Death or Taxes, so excise taxes is probably the one tax that can help you avoid an early death, but is underused in every country. Thanks very much.
Thanks, Prabhat. We're going to make you stand a little longer. Let's have Heather and Adam come on up. My job is simply to allow this discussion to happen. I've already introduced Adam as the Director of the Institute for Addiction Studies. Heather is one of our professors, a global health and tobacco expert, and also the head of our undergraduate programs. But let's get some reactions first. Let's start with Adam.
Thank you so much, Dr. Jha. That was a great talk. I love the way you presented the data in a way that was sophisticated, but also I think a broad audience can kind of understand these take-home messages. I like how you presented basically generalizability of some of these trends across countries, across demographics, both with regards to what smoking does to you in terms of mortality, what quitting does to you, and then the taxes, right? So Howard, do you want me to ask questions now, or do you want to, okay, and I want Heather to be able to ask questions as well, of course. So I think I take a few nuggets from your talk and trying to think about like what are the lowest hanging fruit. Two of them, from my perspective, would be how do we get the word out to reach those people who smoke and they say it's already too late, right? This seems like a low hanging fruit in terms of public health messaging. And so what might you recommend there? And the second thing is maybe the political context of raising taxes, and how do you overcome that? Because it seems it's a very excuse me, very cost-effective way for tobacco control intervention to get what you want.
Yeah.
And there are a lot of other ways, right? Like making cessation treatments more available. Like we go through a list about 20, each of them matter, but perhaps this could be probably the most impactful if you can just make it happen, right?
Yeah. Okay, thank you for those points. So yes, and thank you for the compliment. My wife likes to say, your whole career is simple, don't smoke. Why do you need to do anything else? Your whole career has been like that. But as we all know, in public health, you have to persist with messages over time and adapt to the climates that you need to. So to address your 2 points, one is how do we get the message out to large numbers of smokers who think, oh, it's too late? Well, I think there's a variety of tools, not all of which are price, but certainly if price would be a key part of that, and conveying that in fact that it will help the poor. Now there's a related part of that saying, oh, look, when you do that, you get economists and others saying, oh, look, you're a nanny state. Who are you to judge what's good for a poor person? They're, I think, bringing forth some of the evidence that Jonathan Gruber has brought out, where he actually looked at what do smokers' preferences mean? And if I'm a 20-year-old smoker, I would say, look, piss off, don't tell me what to do. I know the risks, and I'll take lung cancer over being old and decrepit any day. But then when you're 45, you think, oh, I feel not very good. I'd like to quit, but I'm addicted. When Jonathan did some good, very well evaluated and respected economic analyses that said, look, if I compare my current self to my future self, I actually value taxes as an external control mechanism. So in fact, he concluded taxes make smokers happy, as the New York Times spin on this. So I think we need to get that kind of evidence in front of decision makers greater, saying, look, this isn't nannyism, but you're helping people basically invest in their future selves. I think for getting the message out to smokers, a lot of the clever communications that have been done really need to be adapted. And I look at the peak of really good anti-tobacco marketing all came from California when they had the litigation against the tobacco industry, and from the tax increase, there were some earmark taxes, and they hire the same clever advertisers that the tobacco industry does. You know, that famous one, there's two really good-looking cowboys out on that, and one turns to the other, says, "Bob, I miss my lung," right? So people caught that. I think I'd love to see a big tax hike in California, and having some of those resources targeted precisely to this. How do you create really good informational materials, media, public health campaigns, and I would also say primary care. There's still, in the US healthcare system and the Canadian healthcare system, smokers contact the healthcare system repeatedly, and there's so few opportunities to say, hey, could we get you into a cessation clinic? Can we get you into a cessation program? If you sign up, you know, you get 5 lottery tickets. Like, we're missing all those opportunities to try to really, and then we know, and you know from your own work, that even brief physician advice, so that you consider smoking, it's going to be good for you and you'll get all this back, does have an impact. So we are really missing an opportunity for very practical things. On the political side, you're absolutely right. We've got a few. One is tobacco industry obstacles. So they'll argue, oh, okay, tobacco, you're going to have taxes, you're going to have runaway smuggling. The second is a lot of politicians hide behind the poor, aided by uninformed economists that say, oh, you're whacking the poor when you raise taxes. Forgive me, but Angus Deaton, a Nobel Prize winner, was saying these same kind of points. You're hurting the poor. If you point out that in fact the poor are more price responsive, that in fact they get a net benefit and a reductions, then in fact they're better off. So getting that evidence out to mainstream economists, I think, is also part of it. But it's a real challenge. On top of that, you have the fact that the tobacco industry makes $10,000 a death out of tobacco. So they've got huge resources to be able to push into all sorts of stuff. So you know, it's an ongoing struggle. I think my editorial is, globally, tobacco control is a bit lost. What Gro Brundtland and others had done with WHO, and the focusing, go after the industry, go after, raise taxes, we've lost it. The WHO messaging last time is, oh, don't grow tobacco because it's bad for child labor. Come on. That's not the big issue here. It's getting the billion smokers worldwide to quit. So anyway, a little editorial against WHO.
Yeah, so I'll pick up on that WHO theme just a little bit. So I was at WHO in 1998 through the FCTC process, and you posted quickly the picture of the Economics of Tobacco Control booklet, and I just wanted to emphasize to the audience just the importance and the impact of that initial World Bank report on the economics of tobacco. Working in WHO at that time, part of our job was simply to get that translated into as many languages as possible and run all over the world, sharing the data and the results presented in that report. And it was, without that report, there would be no framework convention on tobacco control, because it really provided that economic justification that countries needed, that was essential to shift the discourse around tobacco from being one of a profitable good that was traded globally to being one that was was hurting economics of individual countries, and then also that through taxes, governments could get this elusive win-win situation where they could actually reduce tobacco use, save healthcare costs, and raise income, and through excise taxes. So that was, absolutely critical to getting countries to come to the table to negotiate and to move forward on the process. I actually had the same question a little bit that Adam had, and I want to come back to it because the idea, your first half of your presentation is about the poor whites in the United States and all of the reduction and all of the challenges in life expectancy and these challenges that they face, including tobacco use. We know it's disproportionately used by low-income, low-educated populations here in the U.S. So by raising taxes, whether whether they benefit or not, they are paying a higher percentage of that. And we do politically get that pushback, which is this is a regressive tax, and you're hurting the poor with this tax. And recognizing the tobacco and the public health benefit, do you think there's like an ethical responsibility on governments on how to use that taxation, right? Like I know there's that Thai health model, for example, that earmarks all of that funds to go back into public health. Since it is in a part regressive, is there a responsibility for how that taxation is used?
That's a very good question. That it is true that tobacco use as a proportion of the poorest income is greater. So anything I raise in the prices would by a priori be regressive. But there's a few points to note in that. One is life is regressive in that sense. All sorts of other goods that the poor have to consume, gasoline as a proportion of their income is going to be greater. And I think making the point that, well, if you look at the detailed price elasticity studies that show greater price responsiveness, in fact, you'll get more of the poorest to quit in response to higher price. So for those that quit, they're not, they're better off. So the question is, all right, you raise the price, I'm poor, now I'm paying more, and that's making me worse off. I'm continuing to smoke and I'm paying more. And I think approaches, which comes back to more holistic things, that saying, well, what you want to do is to create programs that use the tobacco tax revenue to try to support cessation or broad health programs. It could be, all right, I'm going to do an anti-obesity program for the poor. And I think many states governments, and this is part of the dialogue which I'd hope, places like Robert Wood Johnson's and others would lead that kind of dialogue with state governments, is saying, you know what, you're getting shafted because the tobacco industry is raising prices and keeping the profits. That if the government did raise taxes, you would capture those and you can actually put it to greater benefits. So not enough of that has been raised at the state level, saying if you want progressive things to reduce the terrible outcomes in the poorest or the lowest education groups, there are effective tools. So this is where I think you need efforts that get broadly civil society, you need CDC and state leadership, and you'd need some foundation leadership. And again, a bit of editorial, as much as I admire Mayor Bloomberg, I don't think the Bloomberg Foundation's focus has been appropriate on this. It's just that it needs to be other parts that really are able to convince states. And then that's the challenge, which is, okay, what can you do? I know you could do it. If you went to the governor of Kentucky and said, this is your state, these are the circumstances, what evidence would you need to present to them saying, this isn't nanny, you're helping the poor, you're giving them a lift up, and you're not getting ripped off by the tobacco industry. So I think all of those things really need to be in place. So I don't know, Howard, who would lead that kind of effort in the US? CDC, others? Because it is a low-hanging fruit.
Not me, not you. We don't have the political skills. I'd like to open this up to the rest of the audience, including folks who are on the chat. But let's see if we have any additional follow-up from Adam.
No one has any questions in the audience?
Again, so, gosh, I have so many comments. I could talk for a really long time. Also, just in agreement in large part about some of the editorial comments you've made in terms of just the impact of the FCTC process and in part the buy-in that countries had in that process and the educational value that it had versus some of the more recent tactics and strategies. One of the things that I'd be really interested, acknowledging that tobacco is still like kind of the gorilla in the room, How do we take what we've been able to accomplish in tobacco, these tax models, for example, and apply it to some of the other risk factors that you presented for this really terrible, shocking data that you showed at the beginning for whites in the US?
Yeah. Well, that's a good one. Guillermo Paraje has a review in BMJ Global Health on alcohol, sugar-sweet beverages, and tobacco taxes, those being the big three. And I think the takeaway message there is not to focus too much on SSBs, because it's really a limited set of evidences from particular populations, like in Mexico, and with very high childhood intake, that they had an impact. And I think to a large extent for SSB shaming, the food industry saying, look, don't put in really high sugar drinks into schools. I think that's starting to occur. We've unfortunately replaced it with environmentally damaging water bottles, which you don't need. But so I think there's some civil society pressure there. But SSBs are actually a small part of it. On alcohol, I think the challenge there is the taxation of that is more complex. You've got potentially for even resorting to homebrew. But what I think a lot more countries could do, what the UK has started to do and some others, is going to unit pricing. And the logic there is, if you look at the harms of alcohol, particularly in younger people, it arises from the high liquor content, cheap booze. That's the one that they really get drunk on. So I think establishing unit pricing, which the UK is trying, effectively they're looking at units of alcohol and trying to have the tax so that it discourages the cheap booze on which you can easily get drunk and which is available. And now that again has this risk saying, all right, you're going after the poor guy and not the snobby red wine drinkers. So they're, I think, trying to get more smarter taxation approaches is possible. Now, one thing to note is some nice work that, what's his name? Last name is Cook. He did, and I think it was really quite informative, is if you look at the US drinking patterns, because the US has this, okay, well, most states you can't drink till 21, it has, my view is that it's actually fostered a binge drinking culture. Particularly, okay, I'm in college, I'm just gonna go nuts, or I'm away from my parents, I'm gonna go nuts. And in that population, there's actually good studies that if you raise the taxes on cigarettes, it decreases binge drinking. So the two go together, right? They're complements. You go to a bar and people are smoking and drinking away, and so the argument is to think about higher cigarette taxes also a way of decreasing binge drinking. So, but these are all complicated public health challenges, but I think trying to figure out to the population that actually, it's you can get huge benefits from cessation, and it equally applies for alcohol cessation, and that to the politicians that you can do a lot of public health good without, somehow moralizing or putting down people. That's a public health set of things that we really need to do, because very little will you have as powerful tools as we have in tobacco control and then broadly in addiction, but we're just not using them.
I have a question. I'm curious, you mentioned China and some Asian countries are predominantly male smokers, and then the risk for their female partners or family members. Can you comment on the strength of the evidence for the secondary smoke effect, and how that's also impacted policy, as that's been a pretty big rationale for some of the policy in terms of smoking and the environment?
Well, there's two ways to look at that. I think, as we were discussing earlier, public health if it's going to maintain the confidence with the public, has to be honest. Because eventually the public will figure it out. The WHO advocacy estimates that said that passive smoking, secondhand smoking, causes 800,000 deaths from smoking or from passive smoking. Just isn't credible. They're basing it on really older, poorly analyzed epidemiological studies. When you put together the most contemporary evidence, there really isn't much of an effect. Now, in confined populations, of course, like we know that flight attendants that worked on Delta Airlines or restaurant employees that had 20 years of exposure did have higher rates of lung cancer, even as non-smokers. But most of the other studies, when they're carefully done, find nothing of that sort. The Million Women study found pretty much nothing. So I think we have to come clean with that, saying, look, there isn't as strong an evidence of passive smoking. WHO resists because of advocacy, saying, oh no, you're going to remove advocacy tool. The second part of it is saying, all right, well, we use passive smoking as an argument for clean air laws and to, well, mostly saying, okay, I'm protecting you from somebody else's smoke. But we should probably come clean, saying the main benefit of clean air laws is actually to raise cessation rates. In the middle of winter, it's a pain to go out of the building and smoke. So in fact, cessation rates go up. I think we should come clean and say, look, okay, you can call us nannies, but we're doing it not just for your benefit, but or not just to protect your neighbor from the passive smoke, but for your own benefit. So, but again, that's an area where advocacy has, the public isn't completely on. The tobacco industry has been bashing the passive smoking argument for years, but no one believes the tobacco industry. But I think it's just a matter of time where enough science comes out and the public will be skeptical. And as you're describing on COVID, people didn't shift quickly enough. I think we need to shift to get people's credibility. What we do know from the passive smoking exposures has been carefully studied is that the risks are really, really quite limited and very, very specific for particular lung cancers and in heavy smoking. And now as there's more smoking outdoors, it's not the case. And the otitis media cases in kids attributable to smoking has also been plummeting. So all the evidence suggests that as an exposure, it's not as important as we had thought.
I think I'll try to ask the last question. And I'm going to ask it to Adam, actually, and yourself as well, which is, of course, we talked about tobacco. We all know that, at least in this country, the industry has pivoted towards vaping and other forms of non-smoking tobacco use. Can we take a global perspective on that trend? Do you have any views on that and what the actual public health impacts might be?
Sure. That's a really good point. So smoking cigarettes on a daily basis is just about like the worst thing you could do for your health, right? Okay, so let's take that there. Okay. Yes, it is true that some other commercial tobacco products are less deadly and potentially significantly less deadly, but in terms of, it's a very low bar to compare to. But let's take that as it is. Of course, if Heather and I don't want to speak for Heather, but if everybody would switch to vaping and that was it, and no kids started vaping, we'd say, okay, go for it. I think globally, what's interesting is the policies in the United States, especially the looming possibility of a nicotine reduction policy whereby combustible cigarettes will be required to be sold at a nicotine concentration that's so low they'd be minimally addictive. That's kind of I believe, an existential threat to the combustible tobacco market in the United States. And because of that, the industry is pivoting and has backup plans and it's they're seeing that, you know, if they want to retain you know, their sales volume, they're going to have to pivot to other products. Whereas elsewhere, where some of the policies, you know, are less robust, and those types of major threats to the tobacco industry are not on the table, you see that there's not a lot of marketing of those products, these non-combustible products. It's still heavy-duty marketing combustible cigarettes. So I think it's an interesting interaction between policies and the industry and how they play against one another.
Yeah, I think exactly.
Sure. I would just add that, I mean, 3 quick points. One is the big vaping debate has been poorly handled by WHO. If you're the tobacco industry and you think, oh, these tobacco control nuts are really eating into our profits and they're annoying, what do we do to, you know, split them? You'd say, let's have them fight over vaping. And I think WHO's leadership has not handled that in serious scientific ways, because it's a nuanced. It's not the case that vaping is the cure to everything in the way of harm reduction, nor is it the case that vaping is just going to replace the whole world of cigarette smokers with teenage vaping potheads that are vaping all the time. And the dialogue really has incredibly broken down. And it's combined with cancel culture. So, oh, you somehow represent the pro-vapers. And we wrote an analysis of doing interrupted time series in 6 countries, looking at basically when vaping products were introduced, cigarette smoking went down. It was published in BMJ. I've never gotten so much hate mail from my ex-friends from tobacco control. So it's been a real failure, I think, globally of the political or the scientific discourse. But I agree with Adam that if you think that, well, you need strategies that could get smokers to quit. You need strategies that would get keep it out of the hands of kids. And you know, Ken Warner, I think, has written the best stuff on strategies that could be followed. You know, practical things like having vaping products sold only in adult stores. You just can't get them at the corner grocery store or the gas station. And then finally, I think one thing governments should be thinking about is they have to regulate nicotine as a market. And I think saying, okay, if you've got small companies or new companies that are not owned by the tobacco industry, and they're trying to compete, they're saying, we want smokers to switch to us. Fine, let that pursue. But what isn't in absolutely any way acceptable is to say, all right, you know, Philip Morris, we'll give you a pass on all the past stuff you've done on misinformation on cigarettes, and with vaping, sure, go ahead and try to market it widely. And there's no way you should trust big tobacco ownership of cessation products. They just have no interest. In the long term, they'll do the economics and say, you know, the best thing would be I design a Marlboro cigarette-looking vaping product, and I'll have it really switchable. So, you know, if the guy is vaping when he's got the money, and if it becomes too expensive, he'll just switch to our cigarettes. And that's their long-term goal. So I would never trust big tobacco to have any sense of, oh yeah, somehow we want the world to switch to vaping. There's no way you can trust them.
But, Adam, Heather, thank you very much.